Good evening, distinguished guests. Today's speaker, Professor Dr. Gobind Babu, panel of experts, and uh, different oncologists. It's a great pleasure to my privilege to welcome you all in today's session. You know, breast cancer is one of the most common cancers in women, and its impact of patients, families, and healthcare system is profound. These symptoms brings together this symposium brings together experts from various fields, and over the course of events, we will hear about the key role of CDK4/6 inhibitors like abemaciclib and also fulvestrant in the treatment of breast cancer. With the mission to win the battle against cancer, Escape Oncology was launched in 2018. Our goal is to use cutting-edge technology in every step of manufacturing and provide world-class anti-cancer medicines to the people of Bangladesh. You will be delighted to know this facility is already approved by European Union GMP and Anvisa Brazil. And this is the only oncology manufacturing facility of Bangladesh which is approved by both these two accreditations. Once again, I would like to welcome you to this symposium, and I look forward to your productive and inspiring evening learning and collaboration. Thank you all.
Thank you, Dr. Shariar. So there is a task for the panel of experts as well as the speaker. There will be 5 prizes for the best 5 questions, and that would be selected by the panel of experts as well as the speaker. So I'll take maybe more than 5 questions, but that will be a rapid fire questions, no delay, because we need to start the next closing ceremony as well as the award giving ceremony at 7:45. So we will finish within this. So without any delay, I would like to request our speaker of this session, Dr. Gobind Babu sir, to come to the dais and start his talk. Dr. Gobind Babu sir.
Good evening, everybody. Thank you for having me here. I know it's towards the end of the conference, and I'm really happy to see all of you here. What I'm going to talk to you in the next maybe 20 minutes is about the role of CDK4/6 inhibitors in breast cancer. Can I have the projection, please? Yeah. So I'm from Bangalore in India, so these are some pictures from my city. So greetings to you from Bangalore. So this is going to be the outline. I'll just talk a little bit about how we have understood in the evolution of breast cancer. I'll just briefly go through a case and tell you what we have been doing so far and how does CDK4/6 get into the treatment of this patient. I'll touch upon the 2 important CDK4/6 inhibitors that we've had, abemaciclib and ribociclib. And I've been involved in the trials of both these drugs in our country. And also touch upon a new study that we've just published called Right Choice. And then talk about the role of CDK4/6 inhibitors in the adjuvant setting and the evidence from 2 studies, the Monarchy and the Natali. And then look at a little bit about the resistance patterns that we see with CDK4/6 inhibitors, because every drug that we use, ultimately there is resistance. So let's be prepared to see how we can overcome this resistance. Right. So for a long time, I'm sure there are a lot of people here who are much senior to me. And when I did start my oncology, breast cancer was just a single disease, one entity. Everybody were treated similarly. We soon understood that there was something called the estrogen and progesterone receptor, and that became a part of the classification of the breast tumors that we see. Soon we understood there was something called HER2 positive, and that left a group called the triple negative breast cancer. So this classification was based on the immunohistochemistry that we do. But today what's come in is the gene profiling, and this is just a snapshot to show you how this gene profiling is done. And from this we have at least 5 distinct types of breast cancers, but this is not done routinely because of the cost in most places. So with that background, let's start with a patient. This is a 45-year-old woman who presented to us with a lump in the left breast for 7 months with occasional pricking pain, no nipple discharge. She had no comorbidities. She had para 3, living 3 children, and she was investigated for this same thing. Her clinical examination showed that there was no palpable supraclavicular nodes. The right breast and left breast were normal. The right axilla were normal. The left breast showed a lump in the upper outer quadrant, 6 by 5.5 centimeters. I think this huge size is very common in this part of the world. She also had left axillary lymph node. These are the baseline scans for you. The liver showed metastatic lesions. The bone scan also showed some lesions, so she was staged as stage 4. So how will you manage this patient? So this is an algorithm that we've been using for a long time. We essentially look at where are the metastases, whether they're visceral or just bone metastasis, what is the ER/PR status, what is the HER2 status, and based on that, we either choose chemotherapy or hormone therapy to treat these patients. And they go through multiple lines of therapies, and ultimately they become resistant. In the premenopausal patients, we also look at ovarian function suppression in whatever way you look at. So this is a Cochrane meta-analysis looking at the evidence that we have to guide us whether we can use chemotherapy alone or endocrine therapy alone. And this meta-analysis was a collection of large data. And if you see the last line, which is in red, this ultimately concluded that endocrine therapy was as effective as chemotherapy, except in those patients where the disease was rapidly progressive. I marked this in red because I'll show you some evidence that's come in against this statement. So this is the timeline of targeted therapies that we had. One of the first targeted therapies in oncology has been tamoxifen. I think we must give credit to that. So this is looking at sequential use of hormones in breast cancer patients. And as you can see, there is a incremental decrement of the responses that we see with each subsequent therapies that we use for these patients. Ultimately, there is resistance. So how do we overcome this endocrine resistance? Let's look at this new group of drugs, the CDK4/6 inhibitors. So you must be wondering why I'm showing you some bacilli, or this toad, or the sea urchin. It's because all these three were important in our understanding of the cell cycle and the role of CDK. So there were 3 people. This is Paul Nurse. This is Lee Hartwell. This is Paul Nurse. And the other person was Tim Hunt. And 3 of them worked on these to actually establish the importance of the pathway CDK. And all 3 of them got a Nobel Prize for this discovery. So I think we must remember people who worked on this, but it's important that we don't forget the history. So a premenopausal patient with hormone receptor advanced breast cancer patient, what is the role of CDK4/6 inhibitors? So this is again looking at the timeline and the development of these drugs. One of the first ones that came out was palbociclib, and then abemaciclib and ribociclib immediately followed. So the introduction of CDK4/6 inhibitors has definitely been an advantage, and this is the data that we have for the 3 drugs, data from Paloma, Mona Lisa, and Monarch studies, showing you that there is an advantage of using the CDK4/6 inhibitors with endocrine therapy versus endocrine therapy alone. So since we have these 3 drugs, we have seen that the consistency of response is there in terms of the duration of progression-free survival. So let's look at some of the data for each one of these molecules. As I mentioned, the studies with abemaciclib is called Monarch, and I'm sure all of you know what this butterfly is. This is the butterfly called Monarch, after which the studies of abemaciclib are named. So this is Monarch 1, that is the first study with abemaciclib. There's a phase 2 study which looked at the role of abemaciclib as a single agent in this study. And the conclusion was that there was objective tumor response as monotherapy for these patients who had several lines of therapy and had become refractory. So this is the first study, the Monarch 1, that gave us evidence that abemaciclib was useful in this heavily pre-treated group of metastatic ER positive, PR positive, and HER2 negative breast cancer patients. So soon this study Monarch 2 was designed, which looked at a combination of abemaciclib plus fulvestrant versus placebo plus fulvestrant. So the primary endpoint, which was progression-free survival, is shown here. The red curve is the one for abemaciclib and the black one is for the fulvestrant alone. And as you can see, at the follow-up of almost 27 months, there's a good divergence of these two curves. So this is the updated data that we have of almost 5 years going on. And as you can see, the curves continue to be divergent. And you can see the hazard ratio, which is pretty significant. And the overall survival as well. So we do have good follow-up for these patients. And even at this follow-up, there is a good divergence. And therefore, we are confident that the use of abemaciclib with fulvestrant, there is an overall survival advantage for these patients. So then this is looking at subset of these patients, looking at whether they had visceral metastasis, bone metastasis, and other metastasis. So we all believe that those patients who have visceral metastasis have much more aggressive disease than just bone alone, and they do badly. This shows that even with visceral metastasis, abemaciclib has an advantage over fulvestrant alone as compared to the advantage that is there with bone metastasis. Now, this is looking at those patients who had primary resistance versus secondary resistance for the endocrine therapy. I'm sure all of you are aware of the definition of primary and secondary resistance for endocrine therapy. And just to refresh, I've just put those two lines as to how you describe or define what primary resistance is and what secondary resistance is. And as you can see here, for those patients who had primary resistance or secondary resistance, the activity of abemaciclib was pretty dramatic. So this is looking at initiation of chemotherapy, and that is because we are trying to see how far we can delay the use of chemotherapy in these patients, because ultimately at some point of time, these patients need to get the benefit of chemotherapy. And what we are trying to see is how much time is there with which we can delay the initiation of chemotherapy for these patients. And as you can see here, those patients who got abemaciclib, they had much longer duration on which they continue to receive abemaciclib as compared to those patients who got fulvestrant alone, with a hazard ratio of 0.674. So that is a good endpoint for us to see, because we are delaying patients getting chemotherapy and having the toxicity of chemotherapy when we use abemaciclib. With that, I will touch upon the other study, the Monarch 3, which is the use of abemaciclib plus an aromatase inhibitors in advanced breast cancer patients. So this is the study designed for you. There were over almost 500 patients, and they were randomized between abemaciclib 150 mg BD versus in combination with the aromatase inhibitors versus aromatase inhibitor alone. And the primary endpoint of this study was the progression-free survival in the intention to treat population. And as you can see here, the difference at a follow-up of 60 months, that is almost 5 years, the difference was 26 versus 9.4 months. And at 72 months, it was 23 versus 4.3 months in favor of abemaciclib. So I think this is good data for us to strongly advocate the use of CDK4/6 inhibitors, and the data for us from this study is for abemaciclib. The secondary endpoint was the overall survival, and again, if you see here, there is a follow-up of over 100 months here and you can see that the arm that got abemaciclib with an AI is doing much better than the arm that did not get abemaciclib. The secondary endpoint, looking at the visceral disease population, again you can see that the curves are diverging out, again in favor of abemaciclib with a hazard ratio of 0.78. So the conclusion from this study was that there were, as I said, almost 500 patients. There were 328 patients who were randomized into the arm of abemaciclib plus an AI. And those patients who got an AI was 165 because the randomization here was 2:1. And the median overall survival was 66.8 months for abemaciclib versus 53.7 months for the placebo arm. This is one of the papers that's recently got published, which is titled as abemaciclib plus non-steroidal aromatase inhibitors or fulvestrant in patients with hormone receptor positive, HER2 negative advanced breast cancer. The final results of randomized phase 3 MONARCH trial, and this was just published this year. And again, I'm happy to show you that I'm one of the authors on this paper. And the conclusion again was that what I've shown you in the earlier slides, that abemaciclib in combination with non-steroidal aromatase inhibitors or fulvestrant provided a PFS benefit and maintained the quality of life in most domains with manageable toxicity profile. And again, to reiterate, this paper actually looked at patients from China, Brazil, India and South Africa. Again, to reiterate that this particular molecule, abemaciclib, is found to be useful in this population as well as compared to the rest of the world. I'm sure you can recognize this lady. This is Mona Lisa for you. And the trials with ribociclib were called Mona Lisa. And this is one of the publications of the phase 3 Mona Lisa 7 study. Again, if you can see my name here, this was published in Lancet Oncology in 2018. And this was the phase 3 placebo-controlled study of ribociclib and tamoxifen or non-steroidal aromatase inhibitors. This was in the premenopausal women, and therefore we added goserelin to take care of the ovarian function suppression. And the conclusion was that the median PFS, which was the primary endpoint, was 23.8 months versus 13 months in favor of ribociclib. This was another paper that we published looking at the health-related quality of life from this particular study. Again, to show you that the patients who got ribociclib plus endocrine therapy, the quality of life was better than those patients who got placebo with endocrine therapy. So given the substantial clinical benefit in terms of PFS and OS that is seen in Mona Lisa 7 and the good quality of life, this is another CDK4/6 inhibitor that is there for your consideration. So I think I've bored you enough, and if there are people sleeping, I'll try to wake you up with this question. Can you draw a rectangle with 3 lines? Yes? Rectangle has 4 lines, right? Okay. I won't waste your time any further. So it's important for you to see the question and understand it first. So how do you draw a rectangle with 3 lines? 1 line, 2 line, 3 lines, rectangle. Okay? So it's important you understand what the question is rather than jump to answering it. Okay, now that I've woken a few of you up, the efficacy of CDK4/6 inhibitors in 2 different settings. I already mentioned about the endocrine sensitive and endocrine resistant cases that we always talk about and the definition. And we have enough data now to say that CDK4/6 inhibitors are effective in both these settings. So as I mentioned, there are 3 CDK4/6 inhibitors. Are they all created equal? So some similarities, palbociclib and ribociclib are similar with regard to their dosing regime, and some side effects that are observed because we give them 3 weeks on, 1 week off, and neutropenia is one of the most common side effects for both of these. And in addition, ribociclib may have a QTC prolongation. So patients on ribociclib, you need to monitor their cardiac function and the QTC for them. Whereas abemaciclib has a continuous dosing. So this probably may be an advantage because patients will not forget when they don't have a confusing regime for them. But the side effect for this is an early onset diarrhea. But I must tell you that although this has been a big problem in the Caucasian population, in the population that we have treated, this has not been a major issue. So it is pretty safe for our patients. So again, looking at the duration of response, which is the PFS for all these trials, which was the endpoint, it was very similar for palbo, ribo, and abemaciclib. So the use of this in premenopausal women, I have shown you the data from the Mona Lisa 7. It's important that we look at ovarian function suppression for these patients when we use an aromatase inhibitor with the CDK4/6. And we know today that this is a good combination, and whether you use CDK4/6 inhibitors or not, having an ovarian function suppression in the premenopausal women has shown to be beneficial across several studies now. So I'll take you back to this slide, which I told you that the Cochrane meta-analysis showed that chemotherapy alone versus endocrine therapy alone. And this conclusion, if you remember, that I showed you in red, was that recommended chemotherapy in patients who had presence of rapidly progressive disease. Why I'm showing you this is because of the evidence that we have today. So this was another study of which I was a part called The Right Choice, which looked at the use of ribociclib plus endocrine therapy versus combination chemotherapy in premenopausal women with clinically aggressive hormone receptor positive, HER2 negative advanced breast cancer. And as you can see, I'm one of the authors on this. This is published in JCO in 2021. And the conclusion from this is the study design, which looked at chemotherapy versus ribociclib plus letrozole plus goserelin for ovarian function suppression. And if you look at the endpoint, primary endpoint, which was the PFS, there was a distinctive difference as compared to chemotherapy. We all believe that chemotherapy is fast acting, and that is the way that you must treat those patients with visceral disease or impending visceral crisis. But this study actually showed that that was not true, and CDK4/6 inhibitors were in fact better than chemotherapy for this group of patients. And you can see these two curves diverging out very, very well. Again, looking at time to treatment failure, this again showed that there was an advantage of using ribociclib plus endocrine therapy. So this was a paper I presented at ESMO Asia last year, and this was looking at the Asian and non-Asian patient difference in this right choice study. And this is just the demographics for you. And what came out of this was that the patients from Asia were doing much better than the non-Asian patients. So if you see the PFS here, that was 14 months for the Asian patients versus 5.5 months for the non-Asian patients. So this is something that was surprising for us, that our patients in this region are doing better as compared to the Caucasians with CDK4/6 inhibitors. So that was in the metastatic disease. So let's see what happens and the role of CDK4/6 inhibitors in the adjuvant setting. Why are we looking at using drugs in the early breast cancer? We today know that approximately 20 to 30% of patients with early breast cancer experience a relapse. And this is a slide to just show you that the relapse in the ER/PR positive patients continues for a very, very long time. They can even have a relapse after 20 years. So therefore, we are trying to see how we can decrease the relapses in early breast cancer. And this is just looking at the recurrence rates by the breast cancer subtype. This is luminal A, B, B2, and basal. And as I mentioned, we don't look at this genomic typing for all our patients. So we are actually looking at other clinical parameters. This is looking at node positive disease. And we know that as the number of nodes involved increase, the recurrence rates increases. Similarly, for the histologic grade, those patients who have a higher grade are doing worse. And this is again lymph node status, a combination of lymph node and the tumor size, again are poor clinical factors. So this is again to show you that the risk of first recurrence after primary treatment in this group of patients is 30% high in within the first 5 years. In fact, if you look at this slide, these curves were very similar when aromatase inhibitors came in, and we were trying to use them over the use of tamoxifen. So similar argument goes for early introduction of CDK4/6 inhibitors. So one of the advances that we have made for this group of patients is the use of CDK4/6 inhibitors. So the study for abemaciclib is called Monarch E, E standing for early breast cancer. And this is, the background again was that early breast cancers have a very early recurrences when they have high risk. So we need to categorize these patients as to what risk they fall into. And this is a study design for you. They got abemaciclib 150 mg BID for 2 years versus endocrine therapy alone. And the primary endpoint was invasive disease-free survival. And as you can see here, at the end of 24 months, there was a difference here. And a follow-up of almost 36 months, the curves are diverging out, again showing you that the use of abemaciclib has definitely decreased invasive disease-free survival for these patients. The distant relapse-free survival was also an endpoint, and again, this shows you that the use of abemaciclib has delayed distant relapse-free survival. So the conclusion from this was, the main conclusion was that there's a reduction in the risk of IDFS, 38.6 months, and distant relapse-free survival of 39.1 month in favor of using abemaciclib for these patients. The other study with ribociclib, again in the early breast cancer, is called NATALI. This is the study design for you. Here, the dose of ribociclib was 400 as against 600 used in metastatic breast cancer. And the conclusion of the study with the investigators was there was an IDFS improvement consistent across all pre-specified subgroups, and DDFS and OS also improved with ribociclib plus non-steroidal aromatase inhibitors versus aromatase inhibitors alone. And if you really want to compare these two studies, there's a very nice write-up that is there, and you can look up this in the ASCO meeting update given by Dr. Heather Moore. So with that, let's look at resistance to CDK4/6 inhibitors. There can be again primary and secondary resistance, and people have tried to see what are the pathways that get overactive, and that may determine the resistance. One of the important ones is the PIK3 mutation, for which we have a drug right now called alpesolib. Of course, this is a drug with pretty strong side effects, especially hyperglycemia. So we're right now doing a study with a new generation of PIK3 inhibitor, which has lesser side effects, and we've accrued 5 patients so far. So the other mutation that has been seen to be producing resistance is the ESR1 pathway. And the secondary resistance is with the CDK2 activation. And therefore, understanding this is important because we now have drugs being designed to target these pathways. RB1 mutation is the other pathway that produces resistance. And secondary resistance can also be because of amplification of CDK4 or 6 as well. And this is just a slide to show you how much of data is being generated and how we are trying to target these pathways and probably reverse the resistance. So I think with that I will stop, and thank you very much for a patient hearing.
Thank you, sir, for your brilliant presentation. Within 25 to 30 minutes, you have covered all the history of available data of CDK4/6 inhibitor. Thank you so much. So the sequence would be we will take the rapid fire questions from the audience, because prize is only for the audience, not for us. We are in the stage, so for the audience only. And I will request all the panelists as well as the speaker to put the mark on each question out of 10. So during the comment session, we will calculate and we will declare the result. So request to the question, who want to ask the question, at first tell your name and then ask the question. But no long questions, we have shortage of time, rapid fire questions. So it depends on where I can see, and I can see one hand, and in the as per commitment from the last session, the breakthrough session, that Dr. Shahida definitely, if got the prize, she will give me the prize as a commitment. Okay, so at first, Dr. Shahida.
No. He raised
Hello.
the hand first. I think you should
I'm a
go
physicist,
Okay.
not physician. I'm Dr. Alamgir Kabir,
Alamgir Kabir. Okay,
Yeah.
ask the question.
Associate Professor, Department of Physics, Jahangirnagar University. How do you think that targeting of CDK2 can help overcome resistance to CDK4/6 inhibitors in HR positive breast cancer cell?
You're talking about
How do you think that targeting of CDK2 can help overcome resistance to CDK4 or 6 inhibitors in HR positive breast cancer cell?
So I showed you some data, why we are having a resistance to CDK4/6 inhibitors. One of them is the ESR1 mutation, PIK3 mutation, RB1 mutation, CDK2 overexpression, several others. So right now we have a drug to target the PI3K pathway. The one that we have is alpelisib, but there are several others coming in. Second, third generation PIK3 inhibitors are coming in. So that's how we will look.
Okay, thank you. Can I ask another question?
I think we should give chance to others.
You can communicate with sir after the session, no problem at all.
Okay, thank you so much.
So I think some volunteer may help from Escape to select the question.
This is me.
Okay.
Not a very rapid fire. Sir, the monarchy, the trial population was stage 3.
Your name,
They
please.
included stage 3 as a high risk. So quite mature data, 36 month and convincing DFS. We are now category 1 recommendation. So then the Natalie trial came, which is also a positive trial, but their population is a stage 2 and a stage 3. So if I consider this 3-year versus 2-year and some cardiac toxicity, would you offer abemaciclib to a stage 2 patient? Because we know this all drugs are same, only the toxicity profile is different.
So that's a good question. In fact, that's why I showed you the paper in which they've compared the two and given the data. So you're talking about cardiac toxicity. What cardiac toxicity are you worried about?
QT interval prolongation.
Okay.
And sir, convincing the patient regarding 2 years versus 3 years. Patients are quite comfortable with 2 years.
Correct. So you need to discuss everything with all the patients. Ultimately, it's the patient's choice.
Yeah.
So the QT prolongation in the Mona Lisa was seen with those patients who got tamoxifen with ribociclib. So it was not with an aromatase inhibitor. So that you really don't need to bother about if you're not giving tamoxifen. So that's
Sir,
important.
that was DVT. In Natalie,
No,
there is
no.
low rate
The
of
QT
DVT.
prolongation. I was a part of the Mona Lisa.
But sir, if I ask you just yes or no, in a stage 2 patient, do you offer abemaciclib?
I give the choice to the patients. I
Choice to the
explain
patient.
everything of how long they have to take, what are the side
We
effects.
we can offer. Though,
Definitely.
I hope the panelist and the speaker also putting the number, because this is important. Next, volunteer, please help me.
Sir,
Okay, tell your name and the question.
I am Dr. Monirani, oncologist. I'm asking questions that for all targeted therapy to need the identify the target, but why CDK4/6 therapy, inhibitor therapy not need any target?
You're asking why we are not looking at CDK4/6, isn't it? Like ERPR, you look for ERPR, right? Because this is a pathway that is there in every cycle, not just cancer cycle, even the normal cycle. Normal cells have this pathway. And we know once in the cancer cell, this is overactive. 100% of the cells, this pathway is present. Like I showed you, the 3 people who got Nobel Prize worked on the bacteria, sea urchin, and the toad. So they're all normal cells on which they worked. So this pathway is important for every cell. But it's overexpressed in all cancer cells. So it's not just breast. Now we know that CDK4/6 inhibitors can be used in other cancers as well. In fact, we're using it in some breast cancer patients where the CDK4/6 pathway is mutated. So that's why we don't even need to look for it.
Thank you.
Next.
Sir, I'm Dr. Ariful Islam. I'm a medical oncologist. My question is, sir, in case of breast cancer progressed on one type of CDK4/6 inhibitor, is there any real-world evidence of choosing a second CDK4 inhibitor, or should we change the classes of drugs to other classes?
So there are two ways of addressing this question. One is you can change the endocrine drug that you have used. If you have used an AI, you can use fulvestrant. In fact, there is data for switching from steroidal to non-steroidal, steroidal to non-steroidal.
Sir, I just want to know that.
Yeah, let me finish my answer. Asking a question before I finish answering. So these are the ways that you can overcome if they are resistant to the CDK4/6. There is small amount of data of shifting patients from abemaciclib to ribociclib and the other way around. Both are there.
Thank you, sir.
Thank you, sir. I am Dr. Monjur. I have two questions.
Only one allowed.
Okay, sir.
So choose what you want to ask.
CDK4/6 inhibitors, how long we should continue the CDK4/6 after achieving complete response? And it is necessary to continue or to reduce the toxicity, we can use intermittently.
So I would use the same principle as using any other drug in metastatic breast cancer. Okay? So if they're responding, continue as long as they respond or as long as they don't have manageable toxicity. It is the same principle that I follow for chemotherapy. The same thing applies here. These are much safer, so we can use it much longer. In fact, I showed you the data that one of the endpoints was the delay in use of chemotherapy for these patients.
Thank you, sir.
Sir,
Assalamualaikum.
hello.
I'm Dr. Shafkat. My question is,
Sorry.
sir, is there any biomarker that can guide us to use the CDK4/6 inhibitor? Sir, from here, I'm Dr.
I
Shafkat.
think we already answered that question. There is no biomarker as of
Already
now.
answered the question.
Yeah,
Thank you.
As of now, no.
Hello, sir. Here is Dr. Rafia Jahan Roshni. I am a very junior trainee in this field. So,
Don't
sir,
give out your age, please.
Okay, sir, I have a very basic query from you, sir. If, okay, we can understand from your presentation there are various data that abemaciclib will be the best option, will be the best choice for metastatic setting, no doubt. But sir, if the patient in Bangladesh, if I'm saying about Bangladeshi people, if the patient cannot afford or refuses after starting up the dosing, then what would be my suggestion or what will I do, sir? Please.
I think before you start, you must counsel them as to whether they can afford or not, whether they're going to take it properly or not. Otherwise, I won't even start. If they're going to take for a weekend stop, what is the point? No point.
Yes, sir, no point.
Yeah.
Thank you, sir.
Thank
My
you,
name is
sir.
Dr. Mohammad Arifur Rahman. How do you often re-challenge the CDK4/6 inhibitor after progression?
After progression.
Re-challenge.
There's no data to say you can re-challenge right now. People are working on it, but there is data to shift from one to the other right now.
No, that's I know.
Yeah.
But do you have any experience to re-challenge with the same drug with progression when the progression is minimally manageable with other modalities like radiation or others?
In a metastatic disease, radiation has a role only for local disease.
That's what I'm asking, sir. Is there any chance that we can locally manage the things with the radiation or other helps? So we
No.
can continue or re-challenge the things?
I understand what you're talking about, like in oligometastatic
Yes,
diseases, lung
yes,
cancer, you can
yes,
give radiation
yeah,
but continue the TKI.
yeah.
We don't have data like that here because we have other options for breast cancer.
Thank
So
you, sir.
I think that is
Last
what
question. Anyone?
I'm afraid whether it is a very lame question or not. Is there any prerequisite?
Name, please.
Is there any prerequisite for? Oh, sorry, sir. Sir, I'm Dr. Salwa Maria Mojumdar, resident from NICRH. Sir, is there any prerequisite for before choosing the CDK4/6 inhibitor? And if there are any kind of prerequisite, that what are they?
I didn't understand your question.
Sir, before giving the CDK4/6 inhibitor, should we look after any type of any comorbidity of the patient? If there is many toxicity may arise after giving CDK4/6.
Yeah. So I think I already
Any prerequisite should be checked before giving the
the most
CDK4/6.
important one is whether they can afford or not.
Okay, sir.
I think that is the most important thing, and you need to counsel that they cannot take it for a few days and stop. So I think that is the most important question that we have for people in this region.
Yes, sir.
Otherwise, there's really nothing else.
Okay, sir. Thank you, sir.
Thank you, thank you. That was the last question. And due to shortage of time, we will not take any questions, as well as I am requesting the panel of experts that we will take your comment not more than 1 minute because we don't have enough time. So I would like to start from Professor Dr. Mohammad Azizul Islam, sir, to make some comment on this topic. And volunteers will collect the numbers.
Bismillahirrahmanirrahim. Our respected today's learned speaker and my dear India, Dr. Gobind Babu, my colleague, panelist, and apologist, learned persons from home and abroad. Assalamu alaikum. Actually, we are delighted to be present here in this session. Topic is CDK4 inhibitors. As we know that we learned a lot because Dr. Gobind Babu is one of the, he is the authority of this ERPR, ERPR positive breast cancer. So we don't have enough knowledge and experience which will be enlightened here, but still we must know that ERPR, if it is positive and HER2 is negative, then the drug of choice is the hormone therapy as well as endocrine therapy. And virtually whenever there is metastasis, so we go for the CDK4 inhibitors and the non-steroid AI. But what is my experience, I have seen that particularly we only write the ER positive. But it is written during the investigations, during reports of the given by the histopathologist or the immunohistochemistry, ERPR has got the grading. Sometimes it is 80%, sometimes it is 90%, sometimes it is 7 by 8, 6 by 8. So what is my experience? I don't have any data, but my experience so far goes, whenever ER is strongly positive, for example, 8 by 8 or 7 by 8, and PR is also strongly positive, for example, it is 7 by 8 or 8 by 8, it is found that the prognosis is much more better and the relapse is very late. So this is my experience. But again, after relapse, we are randomly using the drugs like the CDK inhibitors as well as the non-steroidal AI. But it is found that sometimes CDK4, these are highly effective with endocrine therapy. But it is found that after 5 or 6 years, some drugs, the initial drug which are used initially, for example, in the initial days we used hormone therapy, and after relapse we have used the CDK4s and the non-steroidal AI, and it is found that after the disease progression during the use of the AI or the non-steroidal AI, I have seen that endocrine therapy again functioning well. Not only that, even some other drugs. For example, as Dr. Gobind told that anti-angiogenic factors, anti-angiogenic agent like bevacizumab is also found to be effective in this particular case. So thank you very much for giving me to give comments, and thank you very much.
Thank you, sir.
Thoughtful knowledge. Thank you very much.
Thank you, sir, for your valuable comment. Now, Professor Dr. Mofajjal Hussain, sir, for short comment.
Thank you. About the presentation of Dr. Govind Babu, no comment, please, because he is an excellent presenter, so no comment should be made. Right, about the CDK4/6 inhibitors in ERPR positive and HR2 negative patients, this is actually a wide range of activities, and there are few molecules, pelbo, ribo, and abemaciclib, and the studies have been well shown in the presentation, so I do not have any comment. But these are new avenues and their options, and the treatment can be continued for a long time, say about 5 years even. With ribociclib, we have also our patients, those who are receiving this ribociclib for more than 4 or 5 years, and they are doing excellent. But the problem is with palbociclib, because they get frequently this neutropenia and other problems. So, and abemaciclib can be used even after progression with palbociclib or ribociclib. So these are actually the spectrum of the activities, and eventually the resistance develops. How does it develop? He has explained it. So, but the important thing is the time to start chemotherapy is delayed by several years. So that is the most important part, because patients want no chemotherapy or chemotherapy-free life. So that's my comment. Thank you.
Thank you, sir. Thank you for a valuable comment. Dr. Firdaus Shahriar, sir.
Thank you, Dr. Govind Babu. It's a comprehensive, lecture that he has delivered. And my just take on this, we all know about these 3 molecules, and we've been using it, all of them, especially the first 2, they are quite old. And the last one, yes, we've been using for last maybe not many years, but few years. And the point that, I would like to make about alpelisib, that one. So, what is your experience in your, I'm just asking you a question. In your practice, when you test for this molecular thing in hormone receptor positive metastatic breast cancer, do you do it for every patient or after relapse or something?
For every patient.
Initially?
Yes. And subsequent progression, again, if I can
All
re-biopsy it, I'll
Right.
always look for it, because we have published from our institute, there is a chance of change of these receptors.
Right.
So we need to look at it.
Right.
HER2 can change, ERPR can change. So we
Right.
always do that.
So that's a good point that, we should go for that. Unfortunately, not yet in Bangladesh, we don't have this facility, this NGS and all these things. But we have to send the molecule to this tissue to some centers in your country.
Right.
And yes, I have used one alpelisib in one of my patients after this change. I was in doubt what to do, whether to shift for chemotherapy, but she was not having, visceral crisis.
Correct.
So, this came out as, this, there is a, this mutation.
Yeah, PIK3.
And alpelisib, it's working very nicely.
Correct. So like I mentioned, we are doing a study now for these patients who have progressed on CDK4/6 inhibitors. And this new drug which we're using is essentially a PIK3 inhibitor, but it works even in non-mutant patients. So this study, we have a cohort of patients who are mutant versus non-mutant. So this is a drug which is better than alpelisib in terms of its toxicity. So we are on that study right now.
Thank you.
Thank you.
Thank you, sir, for your nice comment. Now, Professor Brigadier General Kudrat Elai, sir.
Assalamu alaikum, dear audience. Congratulations, Mr. Speaker. It was a wonderful presentation. We are enlightened. In our childhood, we had a story, who is the biggest? Ultimately, they have shown that nobody is biggest. Over time, it changes. Now, CDK4/6 inhibitor, Paloma trial, established palbociclib, then abemaciclib, Monarch, and then ribociclib is the Mona Lisa. For my experience, I use in metastatic cases palbociclib, and result is good because where I serve, the people cannot afford it. But if we consider academically, both abemaciclib and ribociclib is the best. But there is some price problem and also dosing problem. Now, I will request our oncologist for one thing that has been established with Natalie and Monarch E. That is important why we know a good percentage of cases recurrence is a prominent a common finding. So we need to see whether the probability of recurrence is there, because you have to see lymph node is positive, LVI positive. In those cases, we should try to convince those who can affordable either abemaciclib or ribociclib as adjuvant setting. Thank you very much.
Thank you. And lastly, Professor Dr. Shapun Bandyopadhyay sir for final comment.
Thank you, BICC and SFO, and a very cordial felicitation towards the special speaker from Bangalore, India. This is the month of victory. We congratulate you for your beautiful presentation, and as part of being author of so many articles published in the world famous journals. One thing I will be looking forward for your next valuable touch with us, what is or what could be the fate with non-steroidal we are talking, with steroidal aromatase inhibitors. One question that we'll be looking forward in your future occasion. And one thing should be coming from the audience is working in my mind. What is about the cases ER positive, PR negative? And the trials are always telling about both are positive. So some moments of biological differences would be there. Some moment of intensity of ER, PR, overexpression should all be addressed, and biology is always diversified. We are not always concluding, but we are in a changing pace of development in addressing cancer patients. And beloved oncologists must change their mindset to start not necessarily with chemotherapy when the case is ER, PR positive and HER2 negative. Thank you so much again.